So when it comes to the gap therapies, I have a wish list, of course, that I keep talking about with all new therapies in glaucoma. And in this case, I think safety profile equal to or better than a PGA. We're not quite there yet. Some of the other therapies all have safety issues that I think we need to quantify better in our practices. And then long duration of efficacy, 6 to 12 months. We really don't have something that gets us out to 12 months. Although we have achieved patient independence, physician administered and monitored therapies, some of these can be repeated over the lifetime of the patient, and we do get 100% adherence, so we're getting closer to that ideal gap therapy. There are many obstacles for injectables. We're going to be hearing a lot about injectables now that BIMSR has been approved with the trade name Durista. You can imagine a day in the clinic if each patient typically requires 2 injections. Of course, they have a right eye and a left eye. Will we do both eyes in the same sitting? Probably not. What does that do to our clinic flow? Will the drug last 3 months, 8 months? There's no visual clue for the patient like there is with AMD to say, hey, I need a re-injection. I'm going to come in sooner. How do we handle that in clinical practice with glaucoma? How often do you need to see the patient back? Is there a liability in the case of an injection where it only lasts for a month or two and the patient goes for longer without IOP lowering? Of course, we have some of these same issues even with topical therapy. What if they need 2 medications to control the pressure? Would they be willing to get an injection for one of those medications but still need to be on topical therapy? Injections likely need to occur in a procedure room, and many practices don't have a procedure room. How many injections can the cornea take? We really don't know if the clear cornea will be able to take, for lack of a better word, repeated injections over a lifetime, if that is the chosen pathway to inject, for example, Durista several times into the anterior chamber. And then, of course, what happens after the first case of endophthalmitis? I don't know of any reported cases of endophthalmitis from a bottle dropper tip in the case of topical therapeutics, but we do know that with intraocular injections, at some point, a patient's going to get an infection. And how do we handle that? And how does that discussion take place within our field as far as who should get an injection? What is an acceptable amount of risk? All of these questions must be answered over time in the real world. Now, we do know that there are several downsides to topical therapies. We're going to work our way through this list and figure it out. I have great confidence in that. It's just a matter of time, and we're going to learn as we go along. Is medical therapy becoming obsolete? We hear this question over and over again with all these new therapies, and I think the demise of medical therapy is greatly exaggerated. Things are really evolving. Adherence is a main shortcoming, and I think gap therapies might address some of these issues. We have serious hurdles to adoption that I just discussed in the previous slide, like clinic flow and also the financial part of it. Who's going to pay for this? What's the reimbursement? What does it mean to both the patient and the physician's practice? The pace of innovation suggests that drops will not be the primary method of treatment in a decade, but we're still some time away from that, of course. So how do we overcome some of the patient factors that I alluded to earlier? Some of the studies that we've done here at the university focused on these issues. How do we get away from the human factors? We know that patients behave in ways that are counter to their best interests. We know that labeling a patient non-compliant or non-adherent actually increases resistance. There are several fields of medicine that have shown this in different studies. Confronting denial actually increases resistance. So if there's a confrontation between the physician and the patient, it's actually less likely to produce better adherence. Appeals to the fear increase resistance. So if we try to scare the patient into being adherent, that actually has a counterproductive effect on their adherence. Increased knowledge does not always equal behavior change. So trying to educate the patient about the disease process isn't always something that would lead to improved adherence. We tried something called motivational interviewing, and I'll tell you, it was completely brand new to me. I was not familiar with this method of interacting with patients. It's a psychotherapeutic method developed for substance abuse disorders. It is intended to motivate patients who are resistant to their therapy, and it's used in other branches of medicine. I was introduced to this by one of my colleagues in the School of Nursing, Paul Cook, and we started looking at different ways to study this in glaucoma patients. The basic model here is, instead of the medical model of telling patients kind of what to do, asking for questions, and then telling them more, In the case of motivational interviewing, it's more of a eliciting exactly what's important to the patient and then providing them with some answers that will help extract more information out of them. It's more of a balanced interaction with the patient so that they start to recognize some of their own issues rather than the paternalistic telling the patient exactly what to do. We did a randomized multicenter trial with Vanderbilt as well as with Steve Mansberger's group in Portland. And we looked at multiple adherence measures, including using a MEMS cap. This is a bottle that you put the drops into. The whole drop bottle goes into the MEMS device. Every time you would open up the MEMS device, it would record that the patient had an event where they tried to access their drops, and we used that to measure adherence. We looked at psychosocial variables and the potential consequences of non-adherence. All study groups completed baseline surveys, including self-reported adherence. Participants stored their eye drops in a MEMS bottle, as I just mentioned, and they knew, of course, that they were being monitored. And we also gave them reminder phone calls. Our technicians would give them a call on a scheduled basis to discuss their medical therapy. And what we found out is that reminder calls increased adherence compared to usual care based on MEMS. This was not surprising to us. There are other groups, including the group at Hopkins, that have shown that reminder phone calls, pages, emails, texts, all of these things can improve patient adherence. But motivational interviewing, unfortunately in this case, did not have a significant effect on the adherence, but it did produce higher satisfaction than just reminder calls. So that added interaction of eliciting information from the patient produced higher satisfaction within this patient population. All groups had high baseline adherence that limited opportunities for change. So it started off as pretty good adherence in our study. So we didn't get these big bounces from 50% non-adherence to 90% adherence. There was no relationship to adherence within drug classes, stress, social support, knowledge, or doctor-patient relationship. And the take-home from the study is that people with glaucoma have relatively good adherence compared to some of the studies that we had been exposed to prior to this study. Still a lot of room for improvement, but we didn't see a lot of patients who had 40 to 50% adherence, meaning that the majority of their time they were non-adherent. Adherence is related to health and to treatment satisfaction. Team approach might be beneficial, meaning to have phone calls by the technician, in this case, might be very beneficial. Motivational interviewing might improve patient satisfaction. Reminder calls enhanced adherence compared to standard of care. And the question, of course, is motivation enough? If we went through all of this, we had more motivated patients who are more satisfied. Is that enough? And that brings us to another issue with non-adherence, which is the physical limitations as well as the inability to instill drops, regardless of whether there was a physical limitation or not. So we did a follow-up study looking at videographic assessment of glaucoma drop installation to see what the shortcomings were. Could we educate these patients to get better? And then what's the outcome of that education? As I said, the purpose here was to assess the effect of patient education on videotape topical drop installation technique. We looked at drop installation errors, followed by educational sessions on proper drop installation. And then 30 minutes later, the patients were again videotaped instilling drops. The variables that were recorded included the number of drops instilled on each eye, the number of drops reaching the ocular surface, and then the number of times the tip of the bottle touched the eye. So here's one of the patients from our study. We asked this patient to put one drop on the left eye. You can see he started off trying to put it in the right eye. As soon as the drop tip comes close to the eye, he's actually touching the conjunctiva here, and put more than just one drop on the ocular surface. So we did some education, brought the patient back in about a half hour later to do another session. This is that same patient using the left hand as a pivot, right hand puts a drop, no touching of the ocular next conjunctiva, one drop gets on the eye, so much improved. Here's another patient, asked her to put a drop, single drop on the eye as well. She's a little bit confused as to what to do, and you can see here that the drop is getting on the eyelid, getting on the conjunctiva. She's actually rubbing on the eye. several drops actually got onto the ocular surface, and she wasn't 100% sure that the drops were actually getting in. This is a patient who was on medical therapy for glaucoma for an extended period of time. We went through a 30-minute educational session with her, a little bit better, trying to pivot on the left hand but not succeeding. Unfortunately, still touching the eye, touching the cornea, touching the conjunctiva, and several drops getting onto the eye rather than the one drop we actually asked her to instill. So despite the education, not all of the patients got better. There were some patients who simply were not able to instill drops. And for any of the physicians or residents, attendings, fellows who might be listening to this, before you start judging any of these videos that we show from time to time, I think it would be important for you to try and put artificial tears on your eyes and get videotape doing it. I think you'll be surprised by how ineffective it is for even us. We think that we're experts at putting drops on the eyes. When it comes to putting drops in our own eyes, we might not be as perfect as we think. 45 patients with mean age of 56 years were enrolled in the study. Number of drops instilled went from 1.5 to 1.2, so they got a little bit better after the education in getting to that one drop that we asked them to put in. Number of drops reaching the eye, 0.9, went to 1.15, so they were actually getting that drop on the eye a little bit better. Number of times touching the eye improved from 1.7 to 0.5 times, and 29 out of 45 touched the eye. Initially, post-education, 13 out of 45, so they did get better in that regard. And then proper installation was judged at improving from 66% to 82% after the education. Study conclusion: a single educational session on proper use of topical therapy appears to improve installation success. It is unclear if patients will retain the improved installation technique for the long term. Some patients just can't use drops, and I think we need to keep that in mind and try and identify those patients and do a different type of treatment. For the time being, we can do laser, trabeculoplasty, and some of these patients might just need more invasive surgery to improve their outcomes. And of course, we're going to have our hands on the drug delivery products, hopefully over the next few years. Durista, BMSR should be next, hopefully others in the future. There are many things that we did not get a chance to cover: situational barriers to optimal adherence, travel, hospital admissions, things like that. Physician biases that drive clinical decision making. That, to me, is a frontier that we should look at much more clearly as far as how we're affecting the patient care. Link between poor vision and cognitive disorders. We wrote a paper years ago with Brian Yoakum looking at prevalence of cognitive impairment, depression, and anxiety symptoms among patients with glaucoma. I would encourage you to look at that paper. 24-hour IOP measurements, which is another lecture that will be on this channel in coming days, I think is something that we need to look at. And monitoring adherence, how we can actually gauge which patients might be non-adherent. I think these are issues that we still need to get better at. Who can get away with poor adherence to therapy? We know that a lot of our patients, even if they didn't use their drops as we prescribed, are still going to do exactly the way they would if they were using their drops every day. There's just a subset of patients who do very well despite poor adherence. And of course, there are a subset of patients who do very poorly despite appropriate adherence. We just have to figure out those patients that are getting worse because they're non-adherent, and they can do better potentially if we can improve some of their drop installation or sticking to the medical therapy that we're prescribing. What are the overall best practices? Surprisingly, talk to patients. I think this is intuitive. A lot of us are very busy in clinic, and we don't get a chance to talk to them about their drops to try and elicit some of their feelings about how things are going, and also just watching them use their drops after teaching them how to put the drops in. So you should always have an artificial tear around the clinic. You can talk to the patient about how to use it and then ask them to put the drop in while you're watching, and then identify patients who are not good candidates for topical therapy, and then in that case consider laser trabeculoplasty or some of these gap therapies that we're going to have our hands on soon. These are some of the references from our group. A lot of these collaborations happen with Paul Cook from the School of Nursing. You can see we've teamed up with other groups, including those from Nashville with Jeff Kammer, Portland with Steve Mansberger. I'd encourage you to take a look at some of these papers if you want to learn more about motivational interviewing as well as adherence in glaucoma therapy. Thank you very much.